Hello, everyone. For those who don't know me, my name is Vicky Brown, and I'm a Senior Research Fellow with Deakin Health Economics. And I just want to welcome everybody to our workshop on the value of prevention today. Before we get started, I'd like to acknowledge Aboriginal and Torres Strait Islander peoples as the first Australians and traditional custodians of the lands where we live, learn and work. We pay our respects to Aboriginal elders past, present and emerging. We recognise the strong cultural connections of all First Peoples to their land and water across Australia. I'm joining today from the lands of the Wurundjeri people. Please feel free to add in the chat the lands on which you are joining us from. Before we get started, I'd like to thank the Prevention Centre's Collaboration for Enhanced Research Impact, or CERI, and the support of the Prevention Centre's funding partners for the opportunity to present this workshop today. We have a really great lineup today in our workshop on the value of prevention with three highly esteemed speakers who will each speak for about 10 minutes, and then we'll have a Q&A session towards the end. If you have questions for the speakers, please post them in the Q&A function that you should see on your screen, and we'll try to get to as many questions as we can after the conclusion of all three speaker presentations. On that note, I'd like to welcome our first speaker, Pam Nguyen, who will be giving us a brief introduction to health economics. Pam has recently completed her PhD and is a research fellow at Deakin Health Economics. Pam's research focuses on the economic evaluation of obesity and sedentary behaviour interventions. Over to you, Pam.
Oh, thanks, Vicky. Just want to check if you can hear me okay and see my slide.
Yes, we can.
Yep. Right,
Perfect.
thank you. Good afternoon, everyone. My name is Pam, and in the next 10 minutes, I will give a quick introduction about health economics and economic evaluations. Economic evaluation is a systematic approach to assess the efficiencies and value of different interventions, programs, or policies. It is compare the cost and benefits of alternative course of actions to help decision makers allocate resource effectively and make informed choice. Economic evaluation is commonly used in the fields such as healthcare, public policies, and transport. So why health economics evaluation is important? As a society, we have scarce resources while the needs are unlimited. We need to make choice on how we want to use the limited resource for the unlimited needs. Economic evaluations provide evidence on how to allocate our limited resource to deliver the greatest possible values. There are four main types of economic evaluations. The key difference between them is how we measure the outcomes. Cost minimization analysis is used when two or more interventions produce equivalent outcomes. The primary objective is to identify the least costly options among them. Cost effectiveness analysis measures the outcomes in natural units, such as reduction in BMI or increase in serve of vegetables. CEA is particularly common in healthcare to assess the value of medical treatments and interventions. Cost utility analysis is a specialized form of CEA where the health gain is measured in both quantity and quality of life. The key benefits of CUA is it can compare the value of money for intervention across different disease areas. Cost-benefit analysis involves quantifying and comparing all the costs and benefits in monetary terms. The key advantage of a CBA is we can incorporate benefits outside of health sectors. However, there are still difficulties in monetizing health gains. CBA is less common in healthcare, but very common in other sectors such as transport. For any of this type of economic evaluations, we can have within trial or model-based evaluations. Within trial evaluation is where we use only data collected in a trial. We then report the cost per primary outcomes of the trial, and the economic analysis only covers the time period of the trial. On the other hand, modeling is useful for preventive interventions where we want to estimate the long-term health outcomes. Economic evaluation typically involve a series of well-defined steps to assess the cost and benefits of different interventions. In general, we have 6 steps. In step 1, we want to have a well-defined research questions. It means we need a clear descriptions of the problem we want to address through economic evaluations. We also need to specify about the interventions and the alternatives we want to compare and the outcome of interest. We need to determine the perspective from which the evaluations will be conducted. Common perspective include the societal perspective, healthcare provider, and patient perspective. Specify the time horizon is also important, meaning that we state clearly the time period over which the analysis will be conducted. Step 2 is about assessing the costs and benefits. In this step, we identify all the relevant resource use associated with interventions and assign the monetary value to the resource use. Intervention costs may include direct costs, such as treatment or operating costs, or indirect costs, such as productivity loss. When assessing the cost in economic evaluations, we are not just looking at the financial cost, but also the economic cost. For example, in financial cost, we do not cost the volunteer time, but for economic cost, we should consider the opportunity cost when these people doing other work. At this step, we also measure the intervention's outcomes. Depending on the type of economic evaluations, outcomes may include the health outcomes or other outcomes across different sectors. In health-related analysis, this often involve estimating quality-adjusted life years or disability-adjusted life years. The final measure of cost and outcomes need to be adjusted for the time stream of the interventions, which is discounting. And in step 3, we calculate the incremental cost effectiveness ratio. I will show you the equation in the next slide. We first calculate the incremental cost, which is the cost of the interventions minus the cost of the comparator. We do the same for the outcomes. Incremental cost divided by the incremental outcomes gives us the incremental cost effectiveness ratio, the ICER. For the cost utilities analysis, we have commonly accepted cost effectiveness threshold of 50,000 per quality gain in Australia, meaning if the ICER of an intervention is less than $50,000, then the intervention is said to be of a good value for money. In economic evaluations, we also need to conduct sensitivity analysis to assess the robustness of the result variations to the key parameters and assumptions. This helps to access the range of possible ICER values. When reporting the result of economic evaluations, we need to be transparent in all inputs and assumptions we made. So, the common way of reporting cost effectiveness result and demonstrating the parameters uncertainty is using a cost effectiveness plane. This is an example of a cost effectiveness plane. The plane consists of cost axis and the benefit axis. Straight line represents the cost effectiveness threshold. The cost effectiveness plane has 4 quadrants. I will go through each quadrant. First, we have the northeast quadrant in the top right-hand side. It represents the interventions that are more effective, but also more costly than the comparator. Moving clockwise, we have the southeast quadrant. Interventions in this quadrant are considered cost saving because they provide better outcomes while saving money compared to alternatives. Southwest quadrant represents interventions that are less effective and also less costly, while the northwest quadrant represents interventions that are less effective but more costly. The intervention is then said to be dominated. So normally the model has 2,000 runs, and each run represents one dot in the cost effectiveness plane, and the cloud demonstrates the range of the ICER. You can see in the example that the ICER range from cost saving to dominated. And we have 3 clouds representing different scenarios under our sensitivity analysis. So when reporting the cost effectiveness result, we need to take into account the range of ICER and include all the sensitivity analysis finding. And that is also the end of my presentation. Thank you for listening. I will now stop sharing and over to you, Vicky.
Perfect. Thank you so much, Pam. A little bit of Health Economics 101, quick whirlwind tour of health economics there. Just a reminder, if you do have questions for any of the speakers, please put them into the chat function on your screen rather than the Q&A function. I'd now like to introduce our next speaker, Dr. Jaithri Ananthapavan, who is going to share with us her knowledge on building the economic case for prevention. Jaithri is a senior research fellow and leads the economics of obesity stream within Deakin Health Economics and the Global Centre for Preventive Health and Nutrition at Deakin University. Jaithri's research interest is the economic evaluation of preventive health interventions and policies, economic modelling, priority setting, and in methods development to better assist decision makers in using economic evidence in resource allocation decisions. Over to you, Jaithri.
Great, thanks, Vicky. And everyone can see the slides fine? Great. So thank you for that introduction, Vicky, and thanks for the opportunity to present today. So I'll be presenting a couple of examples of economic evidence for prevention. Okay. So Pam has talked about the steps involved in undertaking economic evaluations, and what I just want to make you aware of is that there are different types of economic evaluation studies that are appropriate for different decision-making contexts. So the main distinction I'm making here is between single and multiple intervention comparisons. So single intervention evaluations are appropriate for decision-making related to questions around whether new treatment should replace an old treatment. So this is appropriate for decisions made by the PBAC and MSAC, where economic evidence is used to inform whether a new drug or a new medical device should be funded by the government. However, we know that in decision-making contexts where government is trying to develop a national or a state strategy or a new portfolio of programs, that the evidence provided by single interventions is quite limited. And then studies that provide a comparative assessment of the cost effectiveness of a suite of interventions using consistent methods might be more useful. And we often call these priority setting studies. So given that there are a multitude of potential preventive health interventions, priority setting studies are likely to be more informative in this context. And I'll draw on 2 priority setting studies to give a flavour of the economic evidence base for prevention interventions. So the first study is the Assessing Cost Effectiveness of Obesity Prevention Policies in Australia study, or ACE Obesity Policy, which was an NHMRC funded study which answered the research question, what are the most effective, cost-effective, affordable and implementable policy options to prevent obesity across a range of settings? So I'm going to touch on the methods we used and the results from this study, but all the outputs from the study can be found on the website if you want additional information. So first, just a little bit about the ACE approach. So ACE is an acronym for Assessing Cost Effectiveness, and this is a priority setting methodology for evaluating multiple interventions within one study, was developed by Professor Rod Carter. So there are 2 key features of the ACE approach. First, it uses consistent, standardized, and rigorous methods for the cost effectiveness analysis. And this ensures that the best available evidence is used to inform the evaluations and that the interventions can be compared to each other. But we know that health decision-making is complex, and efficiency or value for money is only one consideration when making resource allocation decisions. And so in order to further assist decision makers, the ACE approach also incorporates broader considerations such as equity, or feasibility to place the cost effectiveness results within a broader decision-making context. So the timeline on the right there shows 5 ACE projects related to prevention. However, although some of these interventions have been commissioned by government, none of them have actually been undertaken to inform government decision-making. So I'm just going to walk through a schematic of the ACE obesity policy model, which was used to evaluate the cost effectiveness of the 16 interventions. So the first step is intervention modelling, where we gather the best available evidence of effectiveness of the intervention and how it would impact the risk factors included in the model. So the risk factors we have in the model are BMI, physical activity, and fruit and vegetable intake. We're constantly adding new risk factors to this model as well. And we also model how the costs of the intervention are implemented across, the cost of implementing the intervention across Australia. So the change in the prevalence of these risk factors for the Australian population is modelled to impact the epidemiology of 9 diseases that are included in the model. And then this translates to improved health outcomes, quantified as health adjusted life years. And as Pam has just mentioned, HALIs or DALIs are a measure of both the quantity and quality of life improvements that result from an intervention. And we also estimate the healthcare cost saving that stems from the intervention's impact on these diseases. We then combine to estimate the cost effectiveness ratio, we incorporate the cost of the intervention with the cost savings to give us the net cost of the intervention, which are then divided by the incremental HALIs to give us the incremental cost effectiveness ratio. And as Pam has mentioned, a value of $50,000 per HALI gained can be considered as cost effective or good value for money in the Australian context. So these are the implementation considerations we looked at for the ACE obesity policy study, which each were assessed across 3 different levels, high, medium, or low. So we looked at the strength of evidence of the intervention having an impact on BMI, as well as an impact on physical activity or diet outcomes, equity impacts, acceptability of the intervention to government, industry, and the public, feasibility of implementing the intervention in the Australian context, and sustainability, which refers to whether ongoing funding is required to sustain the behaviour change for the intervention. For the equity consideration, we looked at both quantitative and qualitative impacts of the intervention on equity. So this is the league table of the 16 interventions ranked by their cost effectiveness results. So here we've reported the type of intervention, whether it's regulatory or programmatic in nature, the incremental cost effectiveness ratio, the total health gains quantified in HALIs, the intervention costs, and the net costs. And you can see here that there are 11 interventions with negative net costs, which basically represent cost savings over the lifetime of the intervention. And this also corresponds to the 11 interventions that are dominant. So 11 out of the 16 interventions are dominant, and 7 out of the 11 dominant interventions are regulatory in nature. So these are the interventions that are both cost saving and health promoting over the long term. So it kind of shows that, you know, these are obvious kind of policies to implement. But I think what we need to keep in mind is that these interventions do cost money to implement. So to implement all 16 cost-effective obesity prevention interventions would cost about $3 billion over the first 3 years, which is actually more than what current spending on all of prevention is. So it really highlights the importance of realising one of the key aims of the National Preventive Health Strategy, which is to increase preventive health spending to at least 5% of total health expenditure. So this is a table with the interventions ranked by the implementation considerations. So we've ranked the interventions first based on the strength of evidence criteria, followed by equity, and then by the number of high ratings for the rest of the considerations. So we've also tried to include here, to give it context, where the intervention lies in terms of its ranking in the cost effectiveness league table. And what you can see here is that community-based interventions are ranked right at the top of our implementation considerations table. However, it's really right down near the bottom of the cost effectiveness league table, just showing that there are lots of different bits of information that need to be considered when we're thinking about what types of interventions should be implemented as part of an obesity prevention strategy. So what I'm trying to show here is that in addition to academic outputs, we really tried hard to provide outputs that are relevant to decision makers. So what we have is a one-page summary of the 16 interventions that we evaluated, simple tables summarizing the results and the key scenarios that we looked at, graphical demonstrations of the results, so the cost effectiveness plane that Pam was talking about, as well as this image down the bottom, which shows the timing of when the costs and benefits accrue and the health gains accrue over time, and a qualitative assessment of how each of the interventions fare for each of the implementation considerations we looked at in the modelling. So the second study we're looking at is the ACE prevention study, and this is an NHMRC-funded study led by Professor Rod Carter from Deakin University and Professor Teo Voss, who was at the University of Queensland, and was completed in 2010. And this really was a very ambitious study that evaluated 123 different preventive health strategies. And it also looked at interventions across a whole range of disease areas and risk factor areas, from mental health to nutrition to osteoporosis. So here are the results of the 123 prevention interventions. So they found that 23 were dominant. So 23 interventions were cost saving and health promoting, and 20 interventions were very cost effective. So they had an incremental cost effectiveness ratio of less than $10,000 per DALY averted. So this graph here shows the combination of the 20 very cost effective interventions. And so along the horizontal axis, you have time. Along the vertical axis on the left-hand side, you have the costs, and the vertical axis on the right-hand side are the health gains. And what it shows is that there is a very high initial investment required to realize the benefits of even very cost-effective interventions. It also shows that it takes time for the substantial cost savings to be realized. And so you really need to have a long-term kind of view on these prevention interventions. You need to maintain them and have political will to continue them over the long term. But if you do, then there really are large benefits to be realized to the population. So although the economic evidence to support preventive health action is building, there is a lot of economic evidence, there still is little evidence of how this has actually been used in decision making. So to finish, I want to reflect on two factors that may improve the use of economic evidence in decision making. So first is that I think the setting of the research needs to change. So this is an example of the mapped decision-making process for obesity prevention policy that was passed in Victorian government. And what we really need to do is try and embed the priority setting study within this very complex decision-making process, so that the whole process from investments, intervention selection, to looking at the actual considerations that are important to decision makers are all really relevant to that specific decision-making context. And second, I think we need to improve the methods and frameworks we use to estimate the benefits of prevention. So we know that prevention requires cooperation and action across various sectors outside of health. However, the benefits we capture in our economic evaluations are limited to health outcomes. But other sectors have other benefits that they're interested in. So until we can capture these various co-benefits of prevention, it's hard to see other sectors being engaged in health sector preventive health policies. So developing methods to incorporate the impact of interventions across sectors could help break down these individual sector decision-making silos and support a more of a whole of government decision-making framework, which is really required for prevention. Sorry, Vicky, I went over, but I'll stop there.
No problems at all. Very interesting. So completely allowed. Thank you so much, Jaithri. Just a reminder, if you've got questions, pop them in the chat and we'll get to them at the conclusion of all three speakers today. Our final speaker is Adjunct Professor Andrew Milat, who is a respected senior executive and leads the New South Wales Ministry of Health Evidence and Evaluation Unit. The unit oversees a substantial portfolio that includes research funding schemes, research impact assessment, the New South Wales Population Health Research Strategy, a strategic research and evaluation service, and Australia's longest running and largest population health training program that employs over 50 trainees in public health, biostatistics, and Aboriginal population health. Andrew's research focuses on implementation science, scale-up impact assessment, and evaluation. And today, Andrew will be sharing his reflections from a policy perspective on the value and the use of economic evidence to support prevention. Thanks so much, and over to you, Andrew.
Right, so I'll share my screen. So can people, sorry about this. There we go. Okay, can everyone see that?
Perfect, thank you.
Okay, great, thanks, Vicky. Look, thanks for that introduction. I'm excited to chat today about some of my reflections as a policymaker on the value and use of economic evidence to support prevention. But I wanted to start today's presentation with a quick series of questions. So I understand that some questions and polls are going to come up on screen now, answering the following questions, starting off with one. Okay, and we're waiting for that poll to sort of take effect. So apologies, Vicky, I'm going to have to slide in and out of screens because I'm in a browser.
No problems.
I can't use Zoom. So the first question was, have you used economic evidence to inform decision-making in relation to a prevention intervention? The second question, have you used economic methods in a research funding grant? Third question, what economic methods have you used in your research or practice? And the final question, and I suspect there won't be very many people who've done this, but interesting to hear people's experiences, have you used economic methods to inform a business case to Treasury? Okay, so I'm not too sure how the results do they pop up on the screen?
I believe that they should pop up on the screen. Alana?
Yeah, so
Yeah.
We've just got 58 people have responded now to the polls. I've got to end the poll to show you the results. Shall we wait a few more minutes for the other 20 or so people to respond, or?
Yeah, look, I think we give 30 seconds or so for people to complete their responses, and then we'll sort of move on. I suppose these are interesting questions because I suppose we have different levels of engagement with economics, and obviously depending on our roles, whether we're researchers or policymakers, working in non-government organisations, I suppose the level of exposure to those different things does differ. So have you used economic evidence to inform decision-making in relation to prevention intervention? 31% said yes. So that's interesting. And that's about what I expect, because it's not something that's used every day. It's an important sort of source of information to inform our decision-making, but it's not an everyday thing from my experience in policy and practice. Have you used economic methods in a research funding grant? It's about sort of 50-50. I suspect that's primarily our research colleagues. So it's great to see that we're seeing a pretty widespread use of economic methods in research grants. The third question was, what economic methods have you used in your research practice? Costing, followed by cost effectiveness, cost benefit analysis, and other. So that's interesting to see what other was, but I suspect it may be a whole range. Economic modelling has been used a little bit, and cost utility analysis, but perhaps not surprising that costing is the most common form of analysis used, because it is important to informing decision making and an important step in subsequent economic appraisal. And then have you used economic methods to inform a business case to Treasury? 5% said yes, and I suspect those are policymakers. And as expected, there's a relatively small proportion of our target audience and policymakers who actually do put these things into Treasury bids. But I suspect over time, and after you see my presentation, there may be more of us doing that who work in a policy setting. So thank you for your contributions to that. Now I'll get my presentation back up on screen. Okay, can everyone see that now?
Just needs to put it in presenter mode.
Okay, great.
Perfect.
So sorry about this. I've had to sort of flip between. I don't have access to Zoom. I have to do it through a browser, so I'm going in and out of documents. So thanks for your patience. So I'd just like to start by saying that there are multiple influences on policy decisions, and I think we can all see this in our everyday life, and sometimes there's a high level of concordance with the policies that we see implemented by governments, by international organisations, and sometimes there's not. And there are multiple influences on policy decision making, and they include things like public opinion, the political ideology that's being implemented, and there are lots of examples of that across the political spectrum in terms of where ideology leads our decision making. We also have some important contributions from research evidence, and economics is a really important part of particularly government decision making, and it's required by treasuries at both a Commonwealth but at a state level, but it's only increasing in importance as a factor in forming policy decision making across the country. So we are in a more tight fiscal environment, and there is a greater expectation of accountability for government expenditure. And applying an economic lens does complement our process and outcome evaluations that we may be doing on initiatives, and provides a more complete assessment of the value of an intervention. And I think reflecting on what Jaithri was talking about, the importance of co-benefits, trying to capture those, not just the direct ones that we often see in health, is a really important activity. So one way of capturing that sort of co-benefit is to put an economic lens on initiatives. It also can be used to build a strong case for prevention and trying to capture the narrative. As we know, narrative is a really important thing. And if we can have as many sources of information that suggest that a prevention activity is a strong case for it, I think adding that economic lens and information to that case is a really important thing. But overall, taking an economic lens also promotes public accountability, learning, and increase public sector effectiveness, because it effectively improves the decision making that governments make about that resource allocation. So highlighting the importance of economic evidence to policy, increasingly across the country, we are in after COVID, a fiscally restrained environment across the country. We are experiencing high levels of inflation internationally, and governments are beginning to introduce much clearer guidance about the importance of economic evidence in informing decision making. The Commonwealth Government has some very clear statements about that. State and territory governments, and including in New South Wales. New South Wales Treasury has released a revision of the New South Wales Government Program Evaluation Guidelines earlier in the year. And those guidelines have a very explicit and stronger focus on economic evidence, and in particular, the importance of cost-benefit analysis as a tool that enables people to compare multiple interventions across a government's portfolio. CBA theoretically can assist a government that may be tossing up whether to build a new hospital, build a new road, build a new school. If you use the CBA method, the theory behind CBA is that you'll be able to monetize those benefits into a single monetary value and compare different interventions. But we know that the reality of that is very challenging. And we can't forget that economics is not the total story. We really do need to have a focus on value. We need to have a focus on equity. And there are lots of other things that should contribute to government decision making, and not solely economics. But there is a very clear push across governments across the country to have a much stronger focus on economic evidence. So what are some of the issues and implications for prevention? Well, economic evaluation is not as widely applied to population health interventions as it is to medical technology and pharmaceuticals. So in actual fact, for the MBS and PBS, there's a very clear set of rules around, whether a drug can be sort of put up and funded by the taxpayer through that scheme, has very clear economic methods, and decisions are made. However, if we look at prevention and interventions across the broader portfolios, there really isn't a sort of consistent way to apply an economic lens to those interventions. Another important thing to consider is that it can be challenging to make an economic case for prevention interventions, as benefits can take many years to manifest. And I suppose this is related to the following comment, which is around discount rates and the fact that they can accrue an early intervention and prevention interventions. And I'll explain what I mean by both of those statements. So essentially, if we are looking at an early intervention program where the benefits, we're dealing with young children, from 6 months to 5 years, for example, it can take often many years for those benefits to manifest. And if we are looking at interventions where there may be a 10, 15, 20-year time lag between exposure to the intervention and the gains that would be made, we apply something called a discount rate. So depending on what jurisdiction you're in New South Wales, and to the credit of New South Wales Treasury, they did drop their discount rate from 7% to 5% based on a bit of lobbying, but also consideration of the facts. But nationally, it still is 7%. Essentially, you have to discount the benefits by 7% per annum. And as you can appreciate, 7% year one, 7% year two, 7% year three, minusing that from the ultimate impact of the intervention will make it very challenging for a lot of activities that are sort of primary prevention and take a long time for benefits to manifest. It really does accrue those compared to those that are, may derive a benefit. You build a road, it takes 3 years. The benefits are sort of start to accumulate straight away. So you can see that some of the challenges associated with preventive interventions and different economic methods. The other point, and I think it sort of picks up on what Jaithri said, is that preventive health interventions are often complex, and they have actions required across various sectors, and the impacts and the benefits that you derive are often in different sectors. And I think it's just picking up on the point that Jaithri made around attempting to measure those co-benefits. And I can give you a very practical example. So some years ago, we conducted a review of the effectiveness of falls prevention programs, and we did a series of economic appraisals of different sort of falls prevention strategies, whether they be expedited cataract surgery, physical activity for balance with older people. So part of the challenge of that was that the methods didn't really allow for co-benefits. So, for example, if we were to increase the amount of physical activity, balance-based physical activity that people do, we would see a reduction in falls. There's very clear evidence and there'd be an economic benefit. However, the models really don't allow for the inclusion of other co-benefits. So it excluded things such as social capital benefits, better social connectedness, improvements in musculoskeletal health. So I think it's really important that we are thinking about the benefits. We try to include as many of those as possible because we will be often underselling the case for a preventive intervention. Often there is also challenges with monetising benefits. It's not a simple exercise. Often where there is a very clear set of interventions and there is a very clear set of outcomes, which, for example, may improve quality of life or extend life, we can monetise those benefits. But in some instances in healthcare and in prevention, it can be quite challenging to actually think about how to monetise those benefits. And there's a bit of work that has to happen in that space because it's not all that data isn't always available across different issues. We also need to think about equity and Treasury in New South Wales recommends doing sensitivity analysis and doing very clear look at the equity impacts, but it's not included in the cost benefit ratio or the net present value. It's more of a qualitative issue. So I suppose my takeout point from all of this is, though economics is important, we shouldn't always have to rely on economic arguments because sometimes what we need to do is important. So if we were to purely apply an economic lens, we'd only provide services to those who it was most efficient to receive that care. So we would provide more care in metropolitan settings and rural settings. We wouldn't focus on high-risk populations because we'd get more benefit from focusing on people who are in the middle to make a change. So I think we have to take these things with a grain of salt, but sometimes we have to draw a line in the sand and actually make values-based decisions, particularly where equity is at play. But you have to play the economic game and prevention has to do the same, and strengthening the case for prevention is a really critical thing. That's the end of some of the issues for consideration, and here are some useful resources that New South Wales Health has on economic evaluation, program logic and evaluation that you might find useful, and they're publicly available and the link is there. So thank you for your time.
Thanks so much, Andrew. Your comments on that lack of a consistent approach to determining what prevention interventions are most effective and cost effective really links back to some of the comments that Professor Andrew Wilson made in the plenary session this morning. And he called for this need for a prevention boosting advisory committee, another form of a PBAC. So alongside a pharmaceutical benefits advisory committee, this need for a prevention boosting advisory committee to start to unpack some of these issues and to bring in more of that consistent type approach to how we consider and fund prevention interventions, which was really interesting. We still have a little bit of time for the Q&A component of the workshop, and I can see that we've got a couple of questions coming in on the chat now. One for Jaithri. Your last point about whole of government decision making to calculate health economics across different sectors is a good point. And wondering what are the obstacles to this and how can those obstacles be addressed in Australia? We'll start with you, Jaithri, and then the rest of the panel can chime in as well.
Yeah, so we did a little, we've done a bit of research in this area in terms of what are the issues for whole of government decision making. And it comes down to a little bit in terms of, you know, what are the structures in place for decision making within governments. And so when you've got financial imperatives to progress specific things in your sector, and so, you know, you get money to try and do something in your sector. So there's no real incentive to try and then do something that's going to benefit prevention. So I think the financial imperatives to actually improve whole of society welfare is missing when you have like those siloed kind of approaches and siloed funding arrangements. but I'm sure Andrew has much more experience with this and more to add. But yeah, I think the silos are really one of the issues in terms of trying to get everyone on board to do what's kind of best for society.
Yeah, I mean, I think that's a really good point. And sometimes there are signals that governments can give to the public sector about sort of being more joined up in our thinking on particular issues. For example, if there's a green space strategy that the government has, that kind of forces together health promoters, town planners, people working in planning, people working in transport. So often those strategic directions and forums where people can communicate across government can then sort of stem some of that sort of siloed thinking. But inevitably, how government operates, it is a series of sort of silos. So I think there's more effort needs to happen to ensure that that siloed thinking is minimised. But it's inevitable as part of any sort of human endeavour, where you have a very clear goal, you want to achieve it. There is that sort of tendency to specialise. But I think there are things like, for example, Premier's priorities. There's something that's been used in New South Wales over a better part of a decade. They can be quite unifying things when we begin to think about a priority that needs actioning. And obesity prevention was a Premier's priority in New South Wales a couple of governments ago. It did galvanise a lot of thought, a lot of investment, and that sort of broke down a lot of those silos.
Yeah, great. We have another question about the ISA threshold, which seems to always draw quite a lot of questions for a whole range of reasons. But that the commonly accepted ISA threshold of 50,000 per alley, quali, dally, as being considered cost effective hasn't changed in several years. And what might be the impact of this figure remaining static moving forward for policy and decision making? Jaithri, do you want to have a go at that? Or I mean, there's so many issues around the ISA threshold. I would start by saying it's a notional indicator. It's an indicator that's required, but there's certainly not. It's not a perfect number. It's not a magic number that's been, magicked out of the air. And but it is a threshold that we require at some sort of threshold. But I do take the point that given, the inflationary pressures and so on that Andrew's been speaking about, there's all sorts of scope for further work and further review into what that threshold is. I don't know if Jaithri, you want to add anything to that?
Yeah, so I suppose also adding that there are different ways to actually calculate the threshold. So this $50,000 is basically based on what people can glean in terms of what was funded from PBAC. So from PBAC decisions, we know that the threshold is somewhere between $40,000 and $75,000. And there's so that's one way of coming up with an idea of what the threshold should be. Another one is kind of like the opportunity cost of getting or attaining a quali gain. So in the health budget, how do we actually get health gains, and what is the cost of getting those health gains? So, there's been work done in Australia where that quali gain might be actually much lower, something like $20,000 or $30,000 per quali, if you're looking at the opportunity cost of health gain in the healthcare sector. And then there's another method, which is about willingness to pay. So, how much are people, decision makers or the public, willing to pay to get this health gain? And there's been less kind of studies done on that, especially in the Australian setting. And that is much more likely to change as for inflation, as income goes up, etc. So it really depends on how you actually calculate that quali gain. In Australia, it's not an explicit number in terms of what that threshold should be.
Yeah, and I guess positing it back within Andrew's comments, where the evidence for cost effectiveness is one part of the decision-making process, and keeping in mind that broader context as well. Andrew, we have one question for you, whether you're able to elaborate on economic evaluations in relation to informing the move toward wellbeing budget.
Yeah, I mean, I think that, you know, the Ardern government was
Australia.
in Australia, but was the first to sort of introduce that in New Zealand a couple of years ago. To be honest with you, I'm not 100% sure. I know we've announced a wellbeing budget for the first time this year in the Commonwealth, and I think it's a positive thing if we do want to try to begin to quantify and monitor a whole range of wellbeing characteristics and indicators as part of our budgeting process. I think that can only be a positive thing for prevention interventions and, you know, health interventions generally, because it sort of opens up a new way of thinking and a new way of operating and prioritising government investment. So I think, in principle, it's a really positive thing, because if you measure it, then, you know, you've got a baseline against which you can compare progress. You also, if you're looking at wellbeing, you know, has a very close alignment with prevention. I suspect in the fullness of time, if it is an initiative that's bipartisan and continued into the future for the country, it would be a really, really positive thing. But I suppose the jury's out, and we'll have to see. But I certainly think it's a step in the right direction.
Yeah, agreed. We've got time for one last question, and this one may be for you, Jaithri and Pam, in terms of tips on how health researchers can best collaborate with health economists, or how they might determine when such collaboration is required.
I'll start by saying every research project should have health economics in it.
No conflict of interest at all.
No.
Yeah.
I mean, I think it's determining who has expertise in different areas of prevention or different areas of health. So quite often how it works with health economists is that you might work in a very specific area, or but we have kind of quite broad skills. So I think if you're trying to implement an intervention and show that it's effective, it's also really important to show the value for money of that intervention. So I would say if your research is about showing the effectiveness of something, you should consider the costs of achieving that effectiveness. But I do take your point that there's probably not as enough health economists in Australia to go around in terms of every grant. But I think, you know, there are big groups out there that actually do economic evaluation. So yeah, try and find them. And the Prevention Centre has great links to all the health economists in Australia.
Which I think segues, we're almost out of time. So thank you everybody for participating. Thank you to the speakers today who have presented really beautifully on all of the different opportunities and challenges for building the economic evidence for prevention. There are some more resources available on the CrowdComms platform in the resources folder. And there are also the contact details of all of today's presenters there. So if you are looking for some health economists or health economics advice, I think the first step is reaching out to somebody working in that field. Once again, thank you to the speakers, and thank you all for joining us, and hope to see you tomorrow for the symposium, where we have 2 workshops and the networking event. At the networking event, we will have a health economics table. So if you'd like to continue these conversations, please join, and I hope to see you there. Thank you, everybody.